I'm going to sort of start the retina section of this presentation by talking about new concepts in imaging atrophy, actually. So these are my relevant disclosures. We have done some work with Centerview as well as a variety of imaging companies related to the Image Reading Center. So it's very interesting that flash color fundus photography, when you think about it for geographic atrophy, it really has been the gold standard. And one of the reasons why I wanted to talk about geographic atrophy in particular is it's kind of a hot topic now in ophthalmology because of the fact that we finally actually have an agent that's in a phase 3 clinical trial. So actually looking at strategies for monitoring atrophy over time in our patients seems to be important. So, again, historically this technology has been flash color fundus photography, and we've got a great definition for GA. We look for sharply demarcated borders, we look for areas of depigmentation, as well as increased visibility of choroidal vessels. And we know that we can use color photography, for example, like Janet Sunnis has done, to track the progression of atrophy. There's actually been some very nice data on how fast atrophy progresses, and all of these trials that you'll be hearing about really utilize this type of information. But at the same time, there are some very important limitations of color fundus photography that have to be considered. And for one, color fundus photography requires good stereopsis for reliable determination of the borders for quantification. And so if you don't have that, you don't have enough contrast sometimes to pick up the borders, like in these examples here. Unfortunately, getting good stereo imaging is not practical in all patients, and particularly in the context of large trials. And in fact, you really need to have a skilled operator in many cases to be able to achieve that. So these significant limitations of standard flash color fundus photography, I think, have really been some of the key drivers in why the technology has been largely supplanted by other imaging modalities in clinical trials of geographic atrophy. So this is an example of a case from Giovanni where, again, the atrophy, you can kind of see it, but it's hard to delineate, whereas other technologies like fundus autofluorescence, OCT, they can really bring this out. So what I want you to consider this evening, and what we've sort of been learning in the Reading Center and being able to use new technologies, is that advances in imaging technology have caused us to rethink the role of color imaging in assessing geographic atrophy. And one of the key advances is in having confocal color imaging capability, like I already alluded to that, but in the Eidon platform. Now, in fact, actually, there are many advantages of the Eidon platform for doing this type of imaging. It's confocal, which means that you have a natural way of enhancing contrast that reduces artifact and lighting irregularity and other problems that can degrade image quality. It's able to cut through media opacity in small pupils much better. It's also a high resolution device, 14 megapixels, so you have good visualization, precise visualization of the GA borders. And of course, one of the most important advantages, and that's why our glaucoma faculty in particular love using the device for capturing their disc photographs and the like, is that the image quality is consistent. And it's because it's automated, it really reduces the need for a skilled operator, which makes a big difference, I can tell you, from a reading center perspective in large clinical trials. Now, one of the things that we need to keep in mind with the Eidon platform, of course, is that it's confocal, but you are still utilizing white light, which again, it's a little different from a flash camera, but for many applications, it's a more natural appearing illumination, if you will, for evaluating fundus pathology. And it's certainly, we had when we started capturing or using the device on some of our initial cases, we started to see some suggestion that there were some advantages for imaging our patients, especially these elderly patients of media opacity and the like. We're able to get a much better visualization of geographic atrophy. So we wanted to really study this in a more systematic fashion, and I guess my slide formatting got changed here, so I wasn't able to acknowledge my research fellows, John Kinlay and Maysal Sheikh, who really did the hard work on the study that I'm going to talk about. But we really want to see if this type of imaging could translate into a benefit for assessing atrophy in clinical trials and clinical practice. So the way we went about doing this is we wanted to, in particular, study the efficiency, which we sort of defined as how many images images are gradable. We saw some examples of images that were difficult to grade. But we also want to look at the reliability. I mean, if we're going to do the grading, two different people look at the same images, are they going to be able to grade the cases similarly? And we want to look at a variety of different imaging modalities, in particular focus on this very interesting problem of atrophy. So this is an IRB-approved study. Patients all signed informed consent. And we didn't focus just necessarily on GA, because one of the emerging concepts in AMD is that when you treat wet AMD, patients long-term, they can go on to develop atrophy. In fact, we call it something different. So far, we've been calling it macular atrophy. But the point is, for the purpose of this study, we didn't distinguish because we wanted to look at both situations. And we obtained multiple different imaging modalities. I'm going to focus more on the color fundus photograph, the flash color fundus photo, and the Eidon confocal color image. But I'll talk a little bit at the end about autofluorescence because Giovanni's going to talk about that more extensively. But let's focus in on the color imaging in particular. And so we had 23 eyes from 14 patients. 12 had macular atrophy in the setting of CNV, and 11 had GA without any previous history of cortical nevascularization. And what did we find first off in terms of the gradability? So maybe this didn't surprise us. Actually, I would say standard flash color photography in this particular study. This is an ongoing study, so it's not complete yet. But actually did pretty good in terms of had a 90% rate. But in a clinical trial, if your 10% of your images is ungradable, that's still not very good. Whereas we were able to perform grading on all of the Eidon images. These are some examples of some of the cases, and I just want to illustrate some of the things that we started to observe because as we start to use the technology. This is an example of a patient. I think you can see the atrophy present here. You can see the hemorrhage as well, so you know this is atrophy in the setting of cortical nevascularization. But notice how you can delineate the areas of fibrosis much better. That's going to be probably a topic with some of the newer agents, maybe the anti-PDGF agents. That may be something important to recognize. We can even recognize other abnormalities such as an epiretinal membrane that you can visualize here. And the other thing I would point out is we could even spot reticular pseudodrusen better, even on the confocal color image. Another example where here you can even spot some of the pseudodrusen on the regular color image, but certainly they stand out better on the confocal color image, but this is again another example of atrophy in the setting of cortical nevascularization. Of course, we also looked at atrophy in the setting of what we're used to, GA in the setting of dry AMD. And again, I think you can see that it's much easier to spot the areas of atrophy. But here I also want to illustrate another difference. It's very hard to see that this patient has an epiretinal membrane on this color photograph, but I think it's very easy to appreciate that with the confocal imaging. It really gives you, we found, very impressive contrast, which again has really changed our perspective on color imaging. You also can spot some of the drusen better here as well. Another example of a patient who had atrophy associated with non-nevascular disease. You can even spot some of these tiny little dots here, which are, of course, calcium crystals, which seem to indicate areas of early atrophy. So we're able to detect those a bit easier as well. And again, I've already pointed out that we had some images that were ungradable. You can imagine there's no way we could grade an image like that in the study in terms of the area of atrophy. So we certainly saw that in about 10% of the cases, and so that was definitely an important advantage. What about the repeatability of the atrophy measurements? When we looked at the repeatability, again, we saw that, not surprisingly, because generally the atrophy was more easy to appreciate on Eidon color image. When you look at the agreement between two graders, you certainly saw consistently higher integrator repeatability, whether it was, especially for when it was atrophy in the setting of CNV. Really, we saw an important benefit of confocal color imaging, and we saw that with less so with integrator than integrator, but integrator is actually more important from a reading center perspective and for use in clinical trials. Oops. Okay, what about autofluorescence? Now, I'm not going to spend too much time on this because Giovanni is going to really introduce and talk about the topic at great length, in particular looking at autofluorescence for other applications. But let me talk about atrophy in particular, because you might be wondering, I've just made a case for wow, suddenly we have this confocal color imaging approach, and we're getting very high quality and to image atrophy. And yes, it's very important to image atrophy in this era now. But what is the role that fundus autofluorescence plays now, since we've got such good imaging? And again, with the Eidon AF instrument, we do have the capability of blue light autofluorescence at 450 nanometers. It's confocal. It's a single frame, so you don't have to expose the patient to a lot of continuous blue light to get it, which is nice. And it has all the other advantages of the Eidon platform that we've already discussed. But where we found that to be helpful, though, is as much as we can grade the atrophy much easier with the Eidon color images, there are rare cases. This was not in that prospective study, but another patient who happened to be in our clinic that we imaged, who, you'd be kind of challenged to pick out the atrophy just because there's a lot of drusen and other things that are kind of obscuring your ability to see it, whereas the autofluorescence, it really does stand out. So there are unusual cases like that where even with the confocal color, it can be difficult. One of the things we're observing, and again, we're sort of in an early phase of understanding the Eidon AF, is that we started comparing it with the spectralis autofluorescence. It is a different wavelength, 450 versus 488, a different confocal aperture. There's a single image versus an averaged image, and there are interesting differences which we are still looking to understand why. For example, notice the optic nerve head isn't as dark on this image compared to this one. So what are the reasons for that? You might have some guesses yourself, but these are still things we're trying to understand. You can also notice the different appearance of pseudodrusen. We can spot the pseudodrusen on the Eidon image, but there are some differences that still need to be characterized. But it's also important to point out that blue light autofluorescence alone is not enough to assess GA. So you certainly have situations of non-foveally involved atrophy, where this is that case I showed earlier. But because blue light is absorbed by the luteal pigment, notice that it makes everything look dark in the center. So you could confuse this and think that might be atrophy. So this really underscores why you really need to have multimodal imaging. Dr. Sarangi will talk about how he's a multimodal imaging supporter. This is just another evidence of support for his case that is important. So again, sorry, this animation is not working quite right, but let me just briefly, again, as I said, we were able to compare between the spectralis and the Eidon autofluorescence as well. And here, we really didn't see much difference at all between the Eidon and the spectralis in terms of the agreement of our graders. They were able to do an exceptionally good job in terms of agreement between graders on assessing atrophy. So to summarize, Eidon, the confocal color imaging, in our experience so far, especially we've been doing this prospective study now, provides excellent and consistent visualization of atrophy, has the benefits of image capture through small pupils in an automated fashion. The repeatability of measuring GA appears to be superior to standard flash color imaging. And to us, it suggests that we really need to revisit the role of color imaging, because it kind of feels like it's been passed by, but actually using the strategy, it seems like there's a real power for assessing atrophy, and combining the color with the AF may allow the optimal assessment of these lesions. Thank you.